Hello, everybody. This is Farah Douglas, President and CEO of the Liver Health Foundation. Welcome to our first Ask Your Liver Doctor webinar. Thank you for joining us. As you know, Liver Health Foundation is a California-based nonprofit 501c3. Many of our board members are representing liver patients and their caregivers. We have a medical advisory council, which is led by Dr. Sami Saab from UCLA. Right now, at this point, we have 25 members, and I believe, and I know that you believe so too, that they are the best hepatologists and liver specialists in the United States. The mission of the Liver Health Foundation is to provide updated and sound information on liver health, promote prevention of liver disease, advocate for quality patient care, and host community and physician-centered webinars and seminars when it's possible to meet the needs of the local liver patients. To see more of the programs that we are planning for 2022, please visit our website at liverhealthfoundations with an S at the end.org. Tonight's webinar is focused on an in-depth review of two rare pediatric liver disease, followed by an informative and one-of-a-kind roundtable conversation between a young liver patient, Elisa McCarthy, and Dr. Katz from Children's Hospital in Orange County. I thank Dr. Sami Saab, who is the MC and host of tonight's program, as well as the chair of our foundation's Medical Advisory Council. We thank our sponsor, Mirum Pharmaceuticals, for their support for this important webinar. We are grateful to Dr. Ebel and Dr. Coley for their participation and support. So our sincere appreciation goes to Mirum Pharmaceuticals for sponsoring this webinar tonight. It is now my pleasure to introduce Dr. Pamela Wig, who is the Chief Scientific Officer at Mirum. Dr. Wig?
Hi, thank you so much, Farah. And really, it's a pleasure to be here and appreciate the time. So I'm Pam Vig, Head of Research and Development of CSO of Mirum Pharmaceuticals. And if we can click to the next slide, please. And I'd like to talk about kind of what we're up to as a very focused rare liver disease company. We're currently across cholestatic liver diseases, if you will, in both pediatric and adult settings. And here on the pipeline, we show maralixibat, which is an ileal bile acid transport inhibitor, or IBAT inhibitor, across 3 cholestatic diseases in children: Alagille syndrome, progressive familial intrahepatic cholestasis or PFIC, and biliary atresia. Recently, we have approval for Alagille syndrome, cholestatic pruritus associated with Alagille syndrome in children 1 year of age or older, which is now called Livmarli. And on the adult setting, we have volixibat, which is also an IBAT inhibitor across 3 cholestatic settings: primary sclerosing cholangitis, intrahepatic cholestasis of pregnancy, as well as primary biliary cholangitis. So this is where we are. We are really dedicated to high need orphan indications. Next slide, please. So just a little bit about ileal bile acid transport inhibitors, or IBAT inhibitors. They interrupt the enterohepatic circulation. And what we mean by that is it interrupts bile acid recirculation. In cholestatic liver disease, there is an extensive increase of serum bile acids, which leads to hepatocyte injury, liver disease progression, and also the ensuing symptomology that is associated with elevated serum bile acids. And what ileal bile acid transport inhibitors do is they reduce the systemic load of bile acids by excreting bile acids through the feces, and thereby we see reductions in serum bile acid, an improvement in pruritus, and an improvement in transplant-free survival. So we're essentially blocking the reuptake of bile acids from the gut back to the liver and excreting them through the feces. Next slide, please. So Livmarli is an oral solution for Alagille syndrome, cholestatic pruritus associated with Alagille syndrome. And I'm going to show you just a little bit of long-term data and the significant effects we see on pruritus as well as on event-free survival. Next slide. So Alagille syndrome is a significantly debilitating cholestatic liver disease in kids. It is a multi-system disease, often affecting the heart, and there's other involvement as well. Those patients who have liver involvement, 88% of them have significant cholestatic pruritus. And what I mean by significant cholestatic pruritus is that it is very debilitating. It significantly affects quality of life, sleep. Parents really have a hard time. The whole family dynamic is very difficult because children aren't sleeping. They're very itchy. They can't quite get at the itch. And so they literally have skin excoriations, bleeding, scarring, and skin mutilation. The pruritus associated with Alagille and these pediatric cholestatic symptom liver diseases can be so significant that it is a leading indication for liver transplantation, even in the absence of disease progression. And 6 out of 10 children progress to transplant or death by adulthood for various reasons, including pruritus as well as liver disease progression. Next slide. So recently at AASLD, which is American Association Study of the Liver, we recently presented an oral presentation in a late-breaking session on event-free survival analysis with maralixibat versus a natural history control cohort. And that natural history control cohort was matched with the maralixibat cohort. And the group is called GALA. So GALA is a natural history research database globally. And once we matched the two cohorts and we saw that that was an appropriate control, we looked at event-free survival out to 6 years. And what we saw was a 70% reduction for clinical outcomes versus the natural history control from GALA with maralixibat. And so in the primary analysis, you see a hazard ratio of 0.305 and a highly significant p-value of less than 0.001. Next slide. And now when we look at the symptomology of Alagille symptom, with pruritus being the most debilitating of symptoms, this is a randomized withdrawal study design, which shows the effect when every patient is on drug, what happens when you control for that. So you withdraw drug for 4 weeks in half of the patients, and the other half of the patients stay on maralixibat. And here you see in red the patients that had the reduction in in pruritus initially. Once the selection pressure is lifted or the drug is taken away, they have a rebound of their pruritus back to baseline levels. And then when they go back on drug, they're able to regain the capture of the pruritus benefit. And you see clinically meaningful and sustained improvement in pruritus a long-term out to week 204. This is data that was recently presented in the Lancet and forms the basis of approval for Livmarli in cholestatic pruritus in Alagille syndrome patients. Next slide. As far as safety goes, the safety data, we have 5 years of follow-up from 3 randomized studies. This is from our US package insert. The most prevalent incidents of effects that we saw were on GI or adverse events of diarrhea and abdominal pain. And this is really expected when you have ileal bile acid transport that is really pushing those bile acids out of the feces. So you see some diarrhea and abdominal pain in the beginning, but they are transient in nature, mild to moderate in severity, and are not increased with increasing doses or time. And there's a lot of information in the US package insert. So you can see the Livmarli prescribing information link. Next slide. So just with that, I just wanted to say thank you so much. We're so excited to have the first approved treatment for cholestatic pruritus in patients with Alagille syndrome 1 year of age or older. This is our beauty shot of our Livmarli campaign. So thank you so much, and I'll hand it back to you.
Thank you so much, Dr. Big. And also, again, thank you to Mirum Pharmaceuticals for supporting this program. It is now my distinct honor to introduce the chair of our Medical Advisory Council and also our MC tonight, Dr. Sami Saab. Dr. Saab has been a great partner for the liver community for, many years. But in particular, he has partnered with me for the past almost 7 years and has helped us provide the programs and services we offer to liver patients and their families. It has been wonderful working with Dr. Saab, and I really want to thank him again. As you know, Dr. Saab is the medical director at Fleger Liver Institute, medical director, adult liver transplant program, chief transplant hepatology, head outcomes research in hepatology, professor of medicine and surgery, adjunct professor of nursing, professor, California North State University College of Medicine, associate editor for Liver Journal of Clinical Gastroenterology. These are among some of the titles that he carries. He takes time to work with me through all this, developing the programs that we do. Thank you, Dr. Saab, for everything you do for all your patients and for us. So with that, welcome, Dr. Saab.
Thank you, Farah, for another wonderful webinar. I also want to, again, thank Dr. Pam Vig for a great presentation. We need each other. And as adult hepatologists, we really lack a lot of information about diagnosis and natural history and treatment of these conditions, and we appreciate her support, and I look forward to tonight's talk. And thank everybody for joining this very important webinar. Farah, I think it's the first webinar we've had focusing on pediatric liver conditions.
Yeah.
And this is a very serious problem, and it's unfortunate, very overlooked. So congratulate you for bringing this to our attention. Our first speaker tonight is Dr. Noelle Ebel, assistant clinical professor at Stanford University, where she's director of the Alagille syndrome program. Her career goal is to improve the health and lives of children with liver diseases, particularly children with complex heart liver disease, and to continue to address health disparities in pediatric liver transplantation, a very important goal. Her clinical research interests lie at the intersection of the heart and liver, particularly for patients who have Fontana-associated liver disease, which is an emerging and an important indication for combined heart liver transplantation, and care for children with Alagille syndrome, with a special attention for patients with liver disease requiring complex heart surgery at Stanford. We're very fortunate to have her today. She remains committed to addressing health disparities in pediatric liver transplantation. And I also want to add that she's a director of policy in the Office of Child Health Equity in Stanford. Without further ado, Dr. Ebel, we look forward to your presentation on Alagille syndrome.
Thanks so much. Dr. Saab, can you see my slides okay? I just want to be sure.
Yeah, I love the purple or the maroon color, whatever color it is.
Okay, perfect. Thank you so much for the introduction. So my name is Noelle Ebel. I'm a hepatologist at Stanford, where, as was mentioned, I'm the director of our Alagille syndrome program here, and I'm so grateful to be invited to give this presentation to you all today. I was given an idea of some of the types of things I should talk about, and I hope I get to all of them. So I put some of the aims here to talk about. First, what is Alagille syndrome? What are the organ systems that can be involved? What's new in the care and management of Alagille syndrome? And what are some of the long-term outcomes? And I wanted to acknowledge that they're both patients and their families and medical providers in the audience. And so I've tried to tailor this presentation, hopefully, to everyone. I wanted to acknowledge that the majority of what I'm presenting comes from the work of our amazing colleagues at the Global Alagille Alliance, or GALA, led by Dr. Benita Kamath. It's an international registry. It includes 67 medical institutions across 29 countries, containing 1,400 plus children with Alagille syndrome. So I wanted to start with the foundation. What is Alagille syndrome? It is an autosomal dominant genetic condition. There are 2 genes that can be involved. 95% of patients with Alagille syndrome have a variant in the JAGID1 or JAG1 gene, and around 2.5% have the Notch2 variant. In terms of how rare it is, we used to think it was around 1 in 70,000 births, and now we think that may be closer to 1 in 30,000. In terms of how you diagnose it, the answer sort of evolved over time. Historically, there were some major and minor characteristics, and I've listed them here. And the phenotypic or clinical diagnosis of Alagille syndrome was considered as 3 of the 7 characteristic features listed. And I've also listed them in the order from most common to least common. Genetic testing to establish the diagnosis of Alagille syndrome has now become the most common, though. How many children with Alagille syndrome have liver involvement? About 95%. 85% of children present with neonatal cholestasis, so that's an elevated direct bilirubin in infancy. And I listed here some of the median lab values of these children that are less than 1 year old. So a median direct bili of 5, ALT in the 150s, GGT in the 400s would be typical. Another aspect of Alagille syndrome is that a number of organ systems are involved, that the number of organ systems involved or the severity of organ systems involved ranges on a spectrum, and it's not predicted by the patient's genetic mutation. So as an example, family members with Alagille syndrome, all in the same family, may have different phenotypes or different organ systems that are involved. Research continues to progress and refine what we know about Alagille syndrome. So the most recent research from the International Registry data suggests that if an infant develops neonatal cholestasis, that about half of these children will require a liver transplant by the time they're adults or 18 years old. In this case, the median age of liver transplant, again for a child with Alagille syndrome with neonatal cholestasis, is about 3 years of age. And the majority of children who present with neonatal cholestasis were transplanted before they were 5 years old. From a patient and provider perspective, Dr. Big already talked about this, so I'll limit this a little bit, but new treatment approaches to Alagille syndrome are related to pruritus or cholestatic pruritus or itching. Historically, children who presented with neonatal cholestasis, about 60%, underwent liver transplantation, with itching being one of the main indications, and simply for quality of life and to ameliorate suffering. And as clinicians, we have had a number of medications in our armament, such as antihistamines, ursodeoxycholic, cholestyramine, which is a bile acid sequestrant, and rifampin. And despite this, we've all treated patients with still breakthrough pruritus. New medical therapies we just heard about, called IBAT inhibitors, have the potential to be disease modifying in patients with Alagille syndrome and decrease the need for liver transplant for pruritus alone. As we heard, bile acids are made in the liver. The accumulation of these bile acids can lead to liver inflammation, which in turn can lead to worsening hepatic fibrosis. About 95% of bile acids are absorbed in the ileum, and the rest is excreted in the stool. So IBAT inhibitors work by blocking that intestinal reabsorption of bile acids and increasing the stool excretion. Clinically, in patients with cholestasis, IBAT inhibitors can reduce serum bile acids, improve itching, and has been associated with improved transplant-free survival. So I started out talking about my favorite organ, which is the liver. And as the director of the Alagille syndrome program at Stanford, it's been an education for me to work with some really exceptional colleagues in cardiology that I pictured here, as well as with the cardiothoracic surgery team and other members of the pulmonary artery reconstruction program. And so I was going to venture into the heart briefly because it can complicate and inform our approach to the liver, with the disclaimer, of course, that I'm a hepatologist and not a cardiologist. So the following couple of slides I'm sharing with the permission of my cardiology colleague, Dr. Jeff Feinstein. So the number of children with Alagille syndrome and congenital heart disease is estimated at around 90%. Dr. Feinstein's takeaway, therefore, is that all children with Alagille syndrome should be evaluated for congenital heart disease. Most importantly, this is because the treatment for congenital heart disease improves both the quality and duration in general of life. And then the interplay between the heart and the liver is an important one, because liver disease can complicate a surgery for congenital heart disease. And conversely, the surgical treatment for congenital heart disease may be required before a patient is actually eligible for liver transplant, and heart surgery can become more complicated as liver disease progresses. So here's a normal heart with the pulmonary arteries shown in pink. And in Alagille syndrome, 75 to 90% of the heart disease is on the right side of the heart. There are a number of congenital heart defects that can be seen, with pulmonary artery stenosis being the most common, as sort of illustrated here with the red circle. To go briefly through some of the heart diagnostic tests, an echo or heart ultrasound is a common test, but it doesn't see the portions of the pulmonary arteries affected in Alagille syndrome well, and it can underestimate the disease. Therefore, other modalities are useful, including MRI and CT. And a lung perfusion scan is another type of test where a radioactive tracer is given by an IV, and then a picture of the lungs is created and it shows where that tracer goes. And if the vessels are smaller or blocked on one side, blood in the tracer will go to the other side. A cardiac catheterization is a procedure under anesthesia that helps to further delineate pulmonary artery anatomy and measure heart pressures. And there are a number of congenital cardiac conditions found in children with Alagille syndrome and listed here. And as Dr. Feinstein mentions, the approach to considering an intervention mentions the approach to considering an intervention like a heart surgery. So for example, for one of the most common lesions, isolated pulmonary artery stenosis, the timing of the intervention depends on the heart pressures and the discrepancy of the blood flow to each side of the lungs. If the heart pressure is low and the blood is evenly distributed, then often this can be observed. If the pressure is high or blood is skewed to one side, then a surgical intervention is undertaken. We've demonstrated that most patients with Alagille syndrome can undergo complete repair with low postoperative right ventricular pressures. And as a reminder, these low right-sided heart pressures are needed before a patient with end-stage liver disease can become a candidate for liver transplant. We also found that complex pulmonary artery disease is not a contraindication to liver transplant in patients with Alagille syndrome. As I personally learn and grow more in the space of taking care of children with Alagille syndrome, I think it's really humbling to see how much we know and also how much there still is to learn. As one example, the understanding of the pulmonary vascular anomalies and the patterns of pulmonary artery stenosis in patients with Alagille syndrome was just recently described. As part of the continuous process of learning and evolving to best meet the needs of our patients, it's important as gastroenterologists and hepatologists to sort of think about the universal screening of other organ systems, and particularly for the most complex patients that require liver transplant or heart surgery. And here I've just listed some of the labs that we've started doing as standard screening for a patient with Alagille syndrome. And for us, maybe it's a little bit different because often we're thinking about a patient that's coming for a cardiac cath or CT surgery, but some of them are sort of generally relevant. One of our current projects is thinking about how to best assess a patient's risk of bleeding prior to a procedure like a cardiac cath or a major heart surgery or a liver transplant surgery, and how to sort of best mitigate those risks of bleeding by coming up with a tailored plan for each patient. And it's been a really wonderful partnership with our hematology colleagues. And I listed again at the top some of the pre-screening labs we've started to get done locally prior to a patient's arrival to just have all the information we need going into their procedure or surgery to be really prepared. Up to 50% of children with Alagille syndrome also have renal disease, and I've listed some of the associated conditions here. We currently do kidney screening for every patient, and that includes tests like BUN and creatinine, cystatin C and a urinalysis with microscopy, and also complete abdominal ultrasound to look at the kidneys. And we're continuing to refine our protocol for which patient should be referred to see nephrology, which thus far is sort of included if a patient doesn't have appropriate renal growth, if they have abnormal renal corticomedullary differentiation on an ultrasound, if they have hypertension greater than the 90th percentile, or any UA findings are abnormal like proteinuria. And we're also working on trying to continue to hone our protocols for patients with Alagille syndrome, specifically with chronic kidney disease and those who are at risk for progression of their kidney disease. So really general things like avoiding nephrotoxic medications like NSAIDs, avoiding pre-renal insults and fluid overload. Children with Alagille syndrome can also have vascular anomalies, and this may include moyamoya, which is a disease where the arteries in the base of the brain are constricted and restrict blood flow. Those fragile blood vessels can proliferate around that blocked artery in an attempt to bypass the blockage. There can be other vascular anomalies like aneurysms, celiac artery stenosis, aortic coarctation, and we do a screening brain through pelvis MRA, similar to most institutions, for a patient once they're old enough to be in an MRI scanner without anesthesia, or much earlier before a major surgery like a liver transplant or heart surgery, or certainly earlier for any neurologic signs or symptoms. I also wanted to mention how much we as gastroenterologists and hepatologists really rely on close relationships with our transplant surgery colleagues. And I know we all feel really grateful for the transplant surgeons we share an expertise with, and also have a strong interest in children with Alagille syndrome. And I just use this last slide to remind myself and us that children with Alagille syndrome can have significant medical complexity. And while it may be less frequent, there's other subspecialty partners that can include neurology, rheumatology, genetics, endocrinology, and ophthalmology, to name a few. So maybe I should have started with this, but I wanted to end with my personal mission, which is to help children with Alagille syndrome achieve their best possible health. And when I started on my journey in caring for patients with Alagille syndrome, Dr. Feinstein, my cardiology colleague, pictured here, was really asking me what's my number one mission. And it's truly evolved over time, and it really centers on the idea that every organ system involved often doesn't function in isolation, with the heart, liver being the perfect example. And for me, that also translates into not practicing in isolation, which is why a lot of this talk included so much more than just the liver. And lastly, I also wanted to express gratitude about how valued and welcomed I've been in the sort of Alagille community, from senior experts in hepatology like Dr. Rohit Kohli, who is presenting today, Benita Kamath, and David Piccoli, for a few examples. And it's been a privilege to learn about sort of the cutting edge of diagnostics and therapeutics, as we also heard about, that's continuing to advance the care for patients with Alagille syndrome. So thank you so much for the invitation to speak today. I'm really grateful for this opportunity. So thank you again for your time and attention.
That was wonderful. I have a couple of questions, if that's okay, while waiting for other people. So how do most kids present? Is it with jaundice? Is it with heart problems, lung problems, cholestasis, pruritus? How do they present?
It's interesting, and it's all different, right? Because it's a syndrome, and so there's so many different presentations. I think we're really biased here. We think a lot about like the initial cardiac presentation without really any liver involvement, and you're sort of detecting the liver secondary to that. Neonatal cholestasis, as I mentioned, would be I guess the predominant presentation from a liver perspective. And sort of similarly, it could be a patient that only had isolated renal disease. So I think it really varies. And we recently had an abstract, but we just sort of looked at patients in general, because you think about, you're operating in a space that's a rare syndrome. It can have a spectrum of ways it can present, and how sometimes in a way, how long it can take to get that diagnosis with so many different manifestations, again, in a rare disease, and how often patients have had to go through multiple subspecialists or multiple visits with a primary care provider before establishing the diagnosis. So it's challenging because it's really different for every patient.
So do we know how long it takes for someone to be diagnosed? I mean, given the uncertainty about diagnosis, does it take months or years before diagnosis is made?
Yeah, and I think it depends too. It's like, how fulminant is that presentation? Is it a patient that with jaundice, and that's a hard one to ignore, or with a cardiac symptom? But I think some patients, I guess anecdotally, struggle in terms of sometimes it can be years, or they've seen multiple subspecialists, and for some, I think it's shorter too. So it varies, but I think the purpose and the benefit of things like this is educating ourselves and providers and families to sort of think about the condition, know the signs and symptoms. So seminars like this are so valuable.
And after liver transplant or heart transplant, they do quite well. I mean, the pruritus resolves, or does it come back afterwards?
Yeah, so it's like I mentioned, that can be it historically was an indication for transplant, and then the liver transplant would be curative of that. And then for those that have, after a cardiac surgery, sometimes they may have significant liver involvement, sort of stage. They go through that major surgery, then followed by a liver transplant. And then in general, what we've written up and we've seen is have really excellent outcomes. And when you think about like liver transplant alone, also having really excellent outcomes compared to other disease processes.
Wow. And have you done heart liver for these patients, heart liver transplantation combined?
No, we haven't done. We've done it for Fontan failure, but not for Alagille syndrome, because the idea is that they have to go to the heart surgery first to be able to have like the lower right ventricular pressures to be a candidate for liver transplant. And so it's also like the purpose in educating ourselves in our community too, because you need this kind of longer runway. You think you have to do the heart surgery, you have to recover from the heart surgery, and the patient with cirrhosis and they develop renal failure, other complications as you're waiting, and now you're waiting for a liver transplant. You need a really long runway to be able to do that successfully.
That's amazing. Wow. I'm not sure if there was any question in the chat room, but that's fascinating. And it sounds like a lot of the lessons that we're learning could translate to adult patients too later on.
I think so too, right? We're always learning from you, as an adult colleague.
No,
and I think it goes both ways. So when it starts with like a pediatric condition that's starting to move more to the adult space, we just started reaching out to our adult partners to say, we're ready sort of to transition these patients, and in doing so, it's sort of an educational process for both of us. So absolutely translates to the adult.
It's important to have partners, both sides. We were talking earlier, I work with Robert Vennick quite a bit, and we have each other's cells, and we touch each other all the time about these issues because, they're different paradigms.
Exactly. Yeah, we learn from each other.
Sorry.
Dr. Saab, I had sent the questions to Dr. Ebel before.
Oh, I'm sorry.
One of the questions that came up afterwards was if Dr. Ebel could talk a little bit about a child that has this syndrome and goes through the surgery and the future of the child, say it's a girl or it's a boy, and they want to know what they can do as far as physical activities, getting married, having children.
Oh, I love that question because we talk about it a lot for liver transplant too. It's I think a privilege as like hepatologists in particular to see a child go through a miracle of a major surgery like a liver transplant. And so we say in theory, unlike other organs that are transplanted, the liver in theory should hopefully last them the rest of their life. And so you think as sort of a secondary thing to also comment on that, it's really nice to see like advocacy groups like the Alagille Alliance, because there's always this huge patient and family component, and you're seeing not only children that have Alagille syndrome who are teenagers who they're like talking to other teenagers and telling them the normal life they lead, but you also see the parents of these children, and some of whom have Alagille syndrome themselves, and we're seeing them in clinic who've had wonderful lives, achieved all the things that they wanted to, had children, of course. So our whole aim is to have them not be limited for their condition, and really just to have them lead their fullest life.
Thank you.
Any more questions, Farah?
No, that was the last question that I had received before sending the questions to Dr.
Wow. Well, Dr. Ebel, that was a wonderful presentation, very enlightening, and it's so comforting to know you're such a great patient advocate. So we hope to keep join us again in the future for other webinars for our patients and our colleagues as well.
Thank you.
So now I'll introduce another dear friend, Rohit Kohli, who I've known now for a number of years. Dr. Kohli has a number of titles. He's a chief of gastrology, hepatology, and nutrition, and director of the George Donald Society of Pediatric Scientists. He's the endowed chair in liver intestinal research at Children's Hospital, professor of pediatrics at Keck School of Medicine at USC. He is a major thought leader regarding obesity and fatty liver, and the role of bile acid signaling as a mechanism for NAFLD. So tonight he'll be talking to us about another rare but essential liver disease, biliary atresia, something that even as adult hepatologists we see, and we always turn for our colleague Dr. Kohli for advice. So Dr. Kohli, without further ado, the floor is yours.
Thank you so much, Dr. Saab. Very kind introduction, and to Ms. Douglas for this opportunity to interact with our patient population. Let's see now. All right. So this is my disclosure slide. I am working with some pharmaceutical companies on research regards to small molecules, and also consult for the companies listed on this slide. I'll leave this up for a few seconds. I will be talking in general about potential therapeutic opportunities in the future, but will not discuss any specific therapeutics. So the outline for today's talk, and I hope there'll be some back and forth thereafter, is to talk about the basics of biliary atresia, which of course will hopefully be thought-provoking for patients that are on the call, on the webinar. What do we currently do for children who suffer from biliary atresia, and what are our outcomes as a community? And the future, what does the future hold for these children, for the children that are not even conceived or born yet, but who unfortunately will be suffering from biliary atresia? So in terms of the American Academy of Pediatrics, Dr. Casper Wong led this publication back in 2015 about newborn screening for biliary atresia, with a task force that looked into it from the Committee on the Fetus and Newborn for AAP. And what they talked about what Dr. Wong talked about was that we should think about screening either using conjugated bilirubin, which is a specific type of circulating blood bilirubin as a blood test, or using physical or virtual stool color cards, to try to siphon and identify early children who potentially may have biliary atresia. This is an example from a publication in Medicine in 2016 of a stool card, a color-coded card, where if you look at the first three, numbers 1, 2, and 3, these are pale clay-colored stools that have been pictured, versus the bottom 4, 5, and 6, which are what we call pigmented stools. Now, the basic difference is in the top 3, there is poor bile flowing into the stool, and therefore there is no color. Unfortunately, that is the same color that then is seen backing up in the elevated bilirubin, manifesting in eyes being yellow or skin being yellow. So the color has left the stool, is not being driven through the intestinal tract, but rather is now more in circulation, higher bilirubin levels. And the normal stools, of course, are at the bottom of the screen. So using such simple tools, there have been successful stories of that as a society in Taiwan, for instance, also in Canada, in the province of British Columbia. They have implemented such screening tools. More biochemical way of doing it was shown by the investigators at Children's Hospital in Houston, Texas, TCH. Dr. Sanjeev Harpavat led this work in 2011, and subsequent work from his group has been path-breaking, where you can see that patients who have ultimately diagnosed with biliary atresia originally had elevated conjugated bilirubin, here outlined as BA, where you have elevated direct bilirubin or conjugated bilirubin, versus controls who are down here at the bottom. And this is at birth, within the first 2 days of life. So you could use either the stool cards or this screening tool in your newborn nursery to pick up children who in the future may have biliary atresia. So those were the basics. So what do we do for these children once they're identified? Now, when you have this atresia or this blockage, this plumbing breakdown, there is going to be a backup of bile. And historically, since the 1950s, is a surgery that is done if the children are identified in time, which is called and named after the surgeon Morio Kasai, who was of Japanese origin, who developed this new novel anastomosis between the intestine and the liver, shaving back into the liver when you do start to see bile flow, and anastomosing the two organs together, such that there is no longer blockage, but you're bypassing the blockage, so to speak, and now you have an open system. And we do not know if there is any other, at the present time, better way of doing this surgery. People have tried through the years and decades past, but to this date, we continue to use Dr. Kasai's procedure for the children that we pick up with this diagnosis. If you look back into the past, this is a few abstracts that I pictured from old textbooks, monographs. And Dr. Peter Altman from Columbia University showed when they did the Kasai procedure back in the 1970s, 1980s, you could see, depending on how old the child was at the time of the Kasai procedure being done, and this is their age of that child in weeks, you can see that the success, which is in the open bars, is much higher under 12 weeks of age. And many fewer children have successful drainage of their bile if the Kasai procedure was done by Dr. Altman and their colleagues at Columbia University older than 12 weeks of age. Across the pond in King's College London in England, Dr. Alex Mawat and his group led a similar study, and they saw very similar outcomes for a distribution. Once you cross this 12-week mark, it is not as good in terms of outcomes. So again, not to belabor the point, the screening becomes essential. We have had much more data, of course, since the 1970s and 80s, and this is another updated version for a combined Columbia University and University of Colorado data set with almost 300 children, and Cincinnati children with another 180 children here. But you will see that, again, the time of the Kasai seems to be still the most important factor. So the timely diagnosis boils down to this: less than 60 days of life, we have 70% success. More than 90 days of life, it falls down to less than 25%. So time is bile. And here's where my research interests in bile acids definitely collides with this diagnosis. So when you talk about biliary atresia and a successful Kasai, that is one thing. Unfortunately, not every child is going to have a timely diagnosis and a successful surgery outcome from Kasai surgery. If you do not have success, it ends up being the #1 indication in children, in pediatrics, under 18 years of age. Biliary atresia is the most common. You can see the blue section of this pie chart here. These are all the cholestatic liver diseases. And the first one amongst these listed cholestatic conditions or blockage in bile flow conditions is biliary atresia. So when you look at it in the North American continent, in Europe, or anywhere else in Asia or so forth, this remains consistent, that biliary atresia does lead to liver transplant as the #1 indication for transplant. We've done well, though. So just to showcase our own program here at Children's Hospital Los Angeles, in terms of medium-term survival from liver transplantation for children, we've done more than 425 now. This is a year-old slide, of which 134, about 33% are living donor liver transplants. This is over the years we've been doing. So 2020, we did 24 pediatric liver transplants. And this year we've done already to date 30. Our 3-year survival is 97%, dated from this report from OPTN. And having done these, you do see that you have successful graduates from these transplant programs, such as from Stanford or from UCLA. Medium-term survival for children today, if you have this diagnosis, is great. So we do need to understand that and say that even if the Kasai doesn't work, we have a backup plan. Now, what about primary liver transplantation? There has been some discussion in our community, in the scientific community, between a primary liver transplant versus Kasai portoenterostomy. This was work that was led out of Vanderbilt by Dr. Alex Hopopoulos' group. And when they looked at it as a national database deep dive, what they saw was, if you can do a Kasai, it is probably, reiterating the point that has been shown before, probably better to do the Kasai very early on in terms of outcomes. However, if you miss the boat on the timing of the Kasai, it may be better to think about transplant. So long-term survival is yet another question, right? This is a picture of a child in 1998. This child received a living donor liver transplant. This is late Dr. Thomas, who developed the program here. May he rest in peace. And Dr. Ginnick, who is our surgical director. This child is now pictured in 2016, standing right to the same two people, with another child that just had received a living donor transplant. So long-term survival, and Dr. Ebel and others can chime in, have with other wonderful stories of this long-term survival. And this is a beautiful picture of the two living donor recipients from 1998 and from 2016 together, celebrating life, as it were. But is that a cure? And two question marks from my side, probably a leading question. I don't think so. This beautiful picture cartoon from Dr. Ott from Belgium showcases how living donation helps a child from an adult. And sometimes, though, it may not be the correct choice, because at the end of the day, if you look at Webster or you look at Oxford in terms of dictionaries, and you look at the word disease, it is something that is being harmed by an external agent, impaired normal functioning. And I think if you take a pill to prevent harm, it is still a disease. And so when I talk to families pre-transplant, I do say, yes, we have good medium and long-term outcomes, but you're still exchanging one set of problems that does not have an imminent solution with a set of problems that is manageable. So I think transplant still is a manageable disease. And if you looked at ideal outcomes, when you're talking about 10 years out, how many of these children who have had a liver transplant are doing ideally, even by our own standards as a community? So this paper written by Professor Vicky Ng from Toronto Sick Kids was using data from the SPLIT research group, or Studies in Pediatric Liver Transplantation, which very interesting anecdote, was initially formulated out of UCLA by our leader at UCLA, Susan McDermott, Professor McDermott. In terms of the actual number of patients who are only taking a single agent, do not have rejection, do not have any complications of kidney injury, it's about only 1 in 3. So at 10 years out, by our own very definitions of an ideal outcome, we are doing 30%. Not a really strong number. So I think we have to understand that this is an exchange of problems. So what's in the future? That's the final set of slides I would like to share. There's a lot going on. We're talking about, this is a recent paper from just a few months ago, on the impact of the procedure, the Kasai procedure, on outcomes, right? We're talking about where do we fall in terms of pushing the envelope within the Kasai procedure. And again, we have this interesting tidbit that comes out that we want to try to do it early. That seems to be still the most important thing that we can take away, is that let's do the identification of these children who need our help early on through their primary care provider, pediatrician, nurse practitioner, or family medicine person who is seeing them. In terms of beyond transplant, there are right now, when I did a search yesterday or day before yesterday on clinicaltrials.gov, 6 active studies, interventional studies for biliary atresia in children that are either in phase 1, 2, or 3. These are those 6 studies. And interestingly enough, 2 of them are working specifically on, as I said, I won't talk about any particular compound, but the genre is, again, intestinal bile acid transport inhibition. Again, my world's kind of colliding with each other here. Now, Dr. Wong, who I started off with the very first slide with the American Academy of Pediatrics position statement on screening, his lab continues to work on biliary atresia, and they've discovered a progenitor stem cell marker called promin1 or PROM1, and showed that to be highly expressed in biliary atresia. In this paper, all the way back now, almost 8 years in hepatology. The more interesting thing is they will be able to show now, these are unpublished that he shared in a communication with me, that there is a decrease in cilia when you have no PROM1. So very interesting finding, because there are certain types we have found of mutations, and this comes from the Children NIH funded network. It was presented last year, I think, at ASLD, where you have defects in cilia. Maybe a small, significant number of children who have biliary atresia have that linkage, that there is a defect in cilia. So linking those 2 things here, Dr. Wong's lab is making some progress between ciliopathy being a player within biliary atresia. Very novel work. So future directions, I think 3 things, if there's any things that you want to take away from my talk today, we need to screen. We need to work with our systems in terms of our newborn nurseries for checking direct bilirubin, conjugated bilirubin. We need to work with our partners in the community to advocate for color stool cards, but screen and identify these children early. If you are too late or the Kasai fails, know that there is a plan B. Transplant is an option. Of course, understanding it is a manageable condition that you're exchanging life for, not an ideal outcome. And then future therapies, please, please, please help with trials when you're approached, and stay tuned for the results. Thank you so much for your attention.
Dr. Kohli, that was wonderful. We do have a question, I think, from Keith Hazelton.
Hi, Dr. Hazelton. What's the question? I don't see it in my Q&A. If you have it, if you wanted to read it off.
I don't see it either. I guess I had her hands up, but I can ask you a different question. So these people that have Kasai procedures as kids, what happens to them as adults if they don't need a liver transplant?
So that's a very
have normal lives, or?
Yeah, I mean, the dogma when I was in training, don't ask me when, the dogma used to be that all children who have biliary atresia will need a liver transplant at some point in their either young childhood or as they get older into adolescence or as a young adult.
Yeah.
There have been reports of children who had been identified to have biliary atresia, even went through the Kasai procedure and have become normal adults.
Wow.
The question that has always been raised, though, by academics such as myself, is that was it an appropriate diagnosis at the origin? Or were these children who, say, had a choledochal cyst or had a different form of BA that we are not dealing with? And I think what we need to acknowledge is that biliary atresia is not a diagnosis. It is an umbrella. It is a diagnosis that has almost akin to Alagille syndrome, of a variation in its presentation. And there may be individuals who have some fibrosis early on. We have to understand that we may have given them a break with the Kasai procedure, and that's all they needed.
Yeah.
But part of my answer is purely speculative.
That's interesting. So I take over a young lady who's a friend of my daughter, and Kasai as a kid, cirrhosis, and at a very young age, I think 20, developed liver cancer. So I think it's important for these individuals, like you brought up, as natural. So we're not sure what happens to patients. Is make sure that we follow them very closely, and then we happened to do an ultrasound and found a mass confirmed with an MRI. But she's doing wonderful now, wonderful, and went to just graduated from college in Florida and doing wonderful. But here I'm dying to hear more about the celiac connection. So does that affect other organs? Are they prone to infection? Can they have kids? The celiac connection.
Not that we know of. I mean, this was mostly gene mutation analysis based out of the Children Network that was picked up with the celiopathy gene, and the linkage may have more to do with bile flow than it does with anything else if you want to extrapolate the data points.
Got it.
And prominent one, which Dr. Wong's lab is studying, also having relations with celiopathy, just piques my interest. But I think so there's some convergence there. But what it proves to me is that not all BA is the same.
That's interesting.
One of the biggest caveats to that diagnosis that is different, has been known for a long time, is biliary atresia, which is syndromic, where you have polysplenia and heterotaxy and sometimes even malrotation along with biliary atresia. So those malformations definitely are tagging along with each other and have to be in some shape or form inherited. However, the vast majority of biliary atresia is isolated. So where's this disconnect? We don't know all the answers yet for sure.
That's interesting. So we have a question in the chat room. If you don't mind, I'll read out to you. But the question reads, what is the risk of liver failure needing a liver transplant if the bilirubin normalizes within a few months of Kasai?
That's a great question. So if you look at the formal definition that we use for a successful Kasai surgery, it is that at 3 months, you are normalizing your direct bilirubin. So if you are 3 months post Kasai procedure and you have normalized your bilirubin, we say that you have a successful procedure. Now, if you look at the natural history studies beyond 3 months, we also know that a third of those who've had a success may still need liver transplant in their young childhood age group.
Yeah.
And beyond that, another third may need it in adolescence. So the very, very few, we just talked about the exceptions in detail before, may escape, and we have to think about their diagnosis and if there's a subset of BA, the standard variety, if there is one. But most children, unfortunately, will fall still into that dogma that I was taught 20 years ago.
Interesting. I find that the CLL conversation fascinating. So what do you tell parents whose kids have undergo Kasai? What do you tell them and what to expect for school and activities, playgrounds, etc.?
I think a successful result, a successful Kasai surgery, just what we described before in the definition, gives a lot of hope of a normal life. We definitely want them to be monitored by their primary care provider and also linked up with a pediatric gastroenterologist or pediatric hepatologist if you're lucky enough to live close to one. The combination of this parental and medical monitoring relieves a lot of the anxiety, I think, and it should, because we can monitor from our side. Is the spleen getting bigger? Is the liver getting stiffer? Are the lab tests changing? And inform the parents of what's coming down the road. And for them to be keeping us informed of does the child have any intervening symptoms, such as that can present with cholangitis, for instance, and a infection of the bile ducts. Do they have a fever? Are the pale color stools coming back?
Yeah.
Are the eyes getting yellow? So that kind of communication between the family and the care network is critical. But if that exists, it should be a much smoother ride.
Wonderful. One more question, if you don't mind. Do kids take prophylactic antibiotics after Kasai's?
So that's variable. I will say that having worked in 3 different pediatric liver transplant programs, I have seen the prophylactic question answered very differently by different very senior and very experienced pediatric transplant physicians and surgeons and hepatologists. So I think if you've had a complication, and this is my kind of personal view, and even people within my practice may disagree with me. So this is kind of putting it together after all these different exposures. If you've had an episode of cholangitis, I think you should be on antibiotic prophylaxis. However, if you have not had you're lucky enough to not have had repeated episodes of cholangitis, then a priori, I don't think there's a automatic knee-jerk need to be on it.
Okay, excellent. Well,
I know that there are differing opinions out there, so I'll leave it at that.
That's a beauty of medicine. Well, Dr. Kohli, thank you for a wonderful talk today and teaching us about this very important complication. I want to also thank Dr. Ebel for her great talk as well, and Dr. Pam Vig from Miriam talking to us about our company. Now I want to introduce Kelly Coletti, the area director West for Miriam Pharmaceutical, and she will talk for us about a few minutes about Miriam Pharmaceuticals. Kelly? I think you're muted, sorry.
Thank you, Dr. Saab. What a wonderful program tonight. We just wanted to thank all of you. We first wanted to thank Farah. I don't know if you're seeing, I think you see Dr. Saab, for our partnership. It's been a wonderful partnership that we've been able to build over the last several months. So I want to thank her. I want to thank you and the Liver Health Foundation for the incredible work that you do to support the local liver patient community. And especially very grateful to have had the opportunity tonight to support the educational program with Dr. Abol, Dr. Kohli, and Dr. Katz. And all of us at Miriam are very excited to bring such a much needed new treatment option to the Alagille patient community with the approval of LivMarley, as you were able to learn more about the rare pediatric genetic disorders and liver disease. So thank you all so much.